he's just learning how to play. He's been playing a couple times a week for the last month, and each time he plays, he's noticing a little bit more pain in his right shoulder.
That's perfect. Thank you very much. Can I get you to take off your shirt, please, sir? Because we've done a history. Please, if you mind? Thank you.
I didn't know I was taking my clothes off.
That's okay. They're all doctors, except for one. The guy in the back, he's not a doctor. He's actually a producer for a reality TV show. Okay, that's terrific. Okay, so what I'm going to do is I'm going to start with, do you want to put your shirt down here, Lynn? What I'm going to do is I'm going to start with inspection. I'm going to have him turn his face, please. And I think that it's key to remember that there's various parts of the shoulder that you're going to forget about. And the one thing that people forget about most often is called the sternoclavicular joint, because it really is part of the shoulder. There's actually 4 joints in the shoulder: sternoclavicular, acromioclavicular, the glenohumeral, and then scapulothoracic. Okay, so any one of those 4 joints can actually contribute to the pathology in this case. So I'm going to inspect, and I'm going to then go around the back, and Len's going to turn around for me, please. And I'm going to look for atrophy. And certainly if you've got a long-standing basis of rotator cuff problems, you're probably going to get some infraspinatus, wasting. And it's not common to see, but when you see it, whoa, that's like the asymmetry of the scapular movement. That's something that you need to consider in your management, perhaps referring to a physiotherapist rather than just giving the exercises. And as a family physician, I think I've tried to tell you folks that there are many times that you can actually prescribe rehabilitative exercises to your patient, and it's just you and your patient, and they come back a couple of weeks later, and then you see how much better they are from what you prescribed. So you don't have to refer everybody with a sports or MSK injury elsewhere. So what I'm going to ask you to do, sir, is I'm going to ask you to turn right around, take your hands out of your pockets, and what I'd like you to do is go all the way up with both arms equally. Can't.
This one, that's a rotator injury.
Oh, okay. That's fine. Well, Judy was close. So let's see how far you can go. And come back down now. And go back up a little bit. And does everybody see that his right scapula and his left scapula are not moving the same way? Okay? And so I think it's really key that as you stand behind your patient, they come up all the way, you're watching to see that it's just symmetrical or not. And there's no magic to that. Either you can tell it, it's as clear as day, or you can't. All right? So now what I'm going to do is I'm going to do some range of motion, and please face me. And so you can see that I do walk around the patient. I turn the patient around. Sometimes the light in my examination room is better at certain angles. Sometimes my student gets in the way, and I move my student so I can see better. Now, Len, can I get you to take your arms and go straight up as high as you can go? High as you can go.
This one I can, but this one,
Okay, so he's cheating a little bit by flexing at the elbow. So his flexion was really only about 110 degrees if he was straight. Okay? Now, external rotation. Think of the stop sign. Len, how much can you do? Can you go up that far?
this one.
With your good one? Okay. Now, external rotation, make sure they don't go into extension like that. External rotation is just comparing how far they can go back like that. All right? It's quite interesting to see an elite level tennis player because they have tremendously increased external rotation on their dominant arm, but they might in fact have decreased internal rotation. And that internal rotation is really going to be diminished to the same degree that their external rotation is increased. And so their total rotation is approximately the same. So what we then do is we then have the patient turn around and we go thumbs up the back to test internal rotation. So can I get you to turn right around and see how high can your thumbs come?
That's it.
How about the good one? The good one come up? Len, you're a great patient. That is great. Okay. Anybody have a guess as to what level that is? I'm sorry? You're closer to 12 because the landmarks are approximately T3 for the spine of the scapula, T2 for the top of the scapula, T7 for the inferior angle. So he was at about 9, something like that. Iliac crest is L3 or L4, and so it's really useful, folks, in family medicine to mark down, and I usually just mark it down, IR, T8R, T6L. And the reason why I do that is because when they come back in a month to see you, then you do it all again, and you can say to the patient, whoa, that's so much better. So if you mark down reduced, or you mark down like an angle or something like that, it's not nearly as effective as when you see that they were at T8 4 weeks ago, and now they're at T6, okay? And I think that that's very important. So, we've done flexion, we've got a degrees of flexion. You know about the painful arc. Sometimes it's between 60 and 120 classically in the book, but it can be starting here. Painful arc is more common in rotator cuff tendinitis, but not always there. In fact, not often there. You have not too much testing of extension. We've done external rotation and we've done internal rotation with the thumbs. So that's basically my inspection. I do sometimes do palpation briefly if there's an issue, but frankly, if there's anything I'm going to skim over, it's going to be palpation. So I'm going to test for sternoclavicular joint tenderness if they're complaining of this area. Sometimes if they've got injury which I think might be an AC separation, which is actually a ligament tear because they've gone bang into a wall, usually in hockey or on the ice. Hockey, the acromion stops and the clavicle keeps going. Okay, so it's like a ligament sprain, very similar to twisting your ankle. And so I'll sometimes palpate over there. But I think that palpation often brings out more pain and defeats some of the things that you're going to do next. So, which is your good arm again? Right is your good arm. Okay. His left is his sore arm. So what I want to do is I want to now get into the special tests. And I'm always doing it in this order. I try and do it in this order all the time. What I'm going to do is I'm going to ask Len to bring this arm all the way up as high as it can go. That's right. It doesn't matter whether he flexes or abducts. So the Queen of England, when she waves, it's sort of like that, okay? And so when you think internal rotation, you don't think that way. Ooh, that's turning outward. But in fact, because the arm is in full flexion, this is in fact internal rotation like that. So external rotation is this, internal rotation is like that. So actually the Neer test is you're trying to turn them into greater internal rotation and seeing if Len's going to grimace or hit me with his other arm, which is his bad arm, so he's not going to hit me so quickly. But the Neer test is just one of the tests for impingement. Okay? I then come down into the bad tasting beer Len. When you pour out a bad tasting beer, you don't pour it out there. You don't pour it out in front of you. You pour it out about 30 degrees in front of the horizontal. Some people call this the Jobe test. Jobe is a surgeon in LA. Turn, 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 turn. Okay, now in that position, thumb down, little finger up. Some people, some of the residents I've seen, they actually have push up. I find it so much easier. Don't let me push down, okay? So Len's got shoulder problems for sure, and he's not comfortable with this side. So hold it right there, Len. And now I'm going to push you down, and you stop me. Stop me. Okay. Can I get you to come on over here? Because Len's not got comfortable shoulders. I'd like you to really turn your thumbs down. That's the way that most patients who are not so symptomatic, they're right over like that, and that would be better. Don't let me push down, stop me. Okay? Good, thank you. And so that is the empty can test. And so the Neer test, the empty can test are just two of the tests for impingement. Now, Len, what I'd like you to do is I'd like you just to bring your arm up like this, right there. And what I'm going to do is I'm going to, would you feel more comfortable with your shirt on, by the way? Yeah, I just wanted to show them your back with your shirt off, so go right ahead.
Why does the Neer test have to be done at such a...
I'm sorry?
Why does the Neer test have to be done at such a... way up here?
If you're doing it like that, it becomes the other one, because you're just doing the internal rotation. It's you know, it's an interesting question, the reason why you ask it that way. I'm just going to tell you frankly, it's in Neer. It's in Reed's book, my favorite big blue book from 1992. It's in the book that way because there's other tests at different angles. And so if you've seen it done here,
This is here, right?
yeah.
And then so I don't understand what this is what it
Well, the reason why is because some structures will be tighter at different angles. And the same thing happens in the knee examination. You know, like, for example, if you're doing an anterior door test in the knee at 90 degrees, you have to really make sure that those hamstrings are loose. Otherwise, it becomes an invalid test because the hamstrings are constraining you from seeing what you're supposed to see. So what we're basically doing is trying to reproduce the internal rotation that stresses supraspinatus, but just doing it at different angles. And that's the reason why we test it there. Thanks, Len. Okay, so now Hawkin's test I think I was at, and I get you to bring it up here. Now, in Reed's book, he's way out here. He's actually abducted. I've always used it this way, done it this way, with his shoulders sort of squared. I say, don't push down. Just let gravity put your elbow into my hand. But where I push you at your wrist, now stop me. Okay, stop me, Lynn. And I look at his face, okay? And a positive test reproduces pain. It is a pain reproduction. And that's the Hawkins test. All right? Now, at the same time that he's in that position, you can do, there's a test called a hornblower test. There's a test called a lift-off test. These are for slightly different areas in the rotator cuff, and frankly, I don't use them. Okay? In Reed's book, which I would have brought today, except it's that big, and I would have arrived 10 minutes later than I actually did, there's so many of these tests, and it's incredible to see that you actually have an opportunity to incorporate these. I've just found over the years that lift-off negative, lift-off negative, lift-off negative, enough already, because it's not adding to my repertoire. I know that I do the Neer, I do the Hawkins, I do the Jobes or empty can test. I know that I'm going to get the yield that I want. My sensitivity and specificity is going to be increased to the degree that either it is or it isn't. Okay? So, the next test for impingement actually does more than impingement. It actually unmasks AC joint pathology, and some people call this the scarf, but I call it the cross-adduction test, and basically I'm bringing him over this way, and does that give you any pain? Okay. So basically we have tested his normal shoulder because his abnormal shoulder is going to bring out all kinds of things, and he's really, you know what, this is a wonderful patient, and we thank you for coming today, but he's actually too sore to show you most of the stuff that I want to do. That's why I'm showing you on his good shoulder. So from those impingement tests, I then move into tests of biceps tendinitis. Okay, and biceps tendon goes through a groove at the humeral head, and I basically employ two tests for that, and one of them is called the Speeds test. And the Speeds test, the way I do it is I just have you put your hand straight in front of you, palms up, and I'm just going to push down and stop me. Don't let me do it, okay? And if that gives them pain, then that I consider a positive Speeds test. I was looking in Reed's book, and Reed's book actually has, it's much more convoluted and complex, and it's like the old game of broken telephone. You know, if a surgeon started using this test in the 1930s, and then his resident sort of made it a little different, and 9 resident generations later, it morphs into something that might not look the same. But in the Reed's book, he's actually got the patient straight, and he's actually resisting supination. Now, when we learned the Yergason test at one of the sport medicine conferences, one of the doctors said, put your thumb in your mouth. And for 15 years, I had patients putting their thumb in their mouth. Okay? This is called the Yergason test. Give me your hand, please. So what I want you to do is I want you to put your thumb in your mouth. Okay? And I'm going to stop. Now, folks, those of you writing down thumb in the mouth, don't do it. Because thumb in the mouth is actually pronation. Yet what you're trying to do is you're trying to resist supination. So what's supination? The hitchhiker. Okay? So now, Len, give me your hand. Hitchhike, please. Up like that. And that's called the Yergason test. And again, it's another test that unmasks biceps tendinitis proximally. Okay? So I do the speeds test, I do the Yergason's test. And this is all in your handout. But it's the hitchhiker. Okay? So, once I get them down in this position, I always want to measure strength. And you'll find that the physiotherapists, they do strength testing in every single way. As a family doctor, I try to figure out what strength is like sort of in the course of this, but honestly, really, I omit it in many cases, and I don't think I'm fooled too many times. But the one strength testing that I absolutely do all the time is external rotation. And external rotation you measure with their elbows on their sides in this position. So Len, can I have you do that, please? All right, and I am going to push you this way, stop me. All right? Good. And I can actually move his left more easily, although he's pretty strong, and his left is his symptomatic side. So, you know, you can measure abduction strength like that. That's actually part of the neck testing, and, you know, in the context of examining the shoulder, yes, you should do an evaluation of the neck, and you should do an evaluation of the elbow, because the joints above and below can often fool you that that's where the pathology actually is, and therefore you get a surprise, such as we did with the pneumothorax yesterday in the clinic. So these are the tests that I basically do for impingement, biceps, tendinitis. And why do I measure ER strength? Any ideas? Okay, so external rotation. Let's back this up a little bit, and let's ask. I'm sorry?
It's usually part of the pathology.
The pathogenesis.
Pathogenesis.
Exactly, exactly. The 4 rotator cuff muscles are? I think I heard them all. I think I heard them all. But the teres minor and your infraspinatus are your external rotators. And think of it like this. Baseball fans. Any baseball fans? Baseball's in the playoffs now. Okay? So the Blue Jays pitchers, they take their arm, they go back like this. It's all big muscles, big muscles, big muscles. So their lats, the latissimus, the deltoid, the pecs are coming into play, and all of a sudden they release the ball, and something other than the skin has to stop the arm from going to home plate with the ball. And those are your rotator cuff muscles, and they're very, it's like fine tuning. It's like, you know, none of you will remember this, but Scott and I remember the fine tuning on the TV sets, you know. We used to tune to channel 9, and then it would be fuzzy, and you'd have to do this little dial like that. Well, the rotator cuff is this very fine tuning. But your external rotators, what they do is they help keep your humerus down and out of the impingement position. Without strong external rotators, without strong infraspinatus and teres minor, you're going to actually have more impingement. And it's a vicious cycle. You injure this, you get neural inhibition, the muscles stop working very well, you get more impingement. It's a vicious cycle, and that's what you have to break, or at least your physiotherapist will help break that if your exercises are not going to do it. And the exercises that I prescribe include strengthening supraspinatus and strengthening external rotation. But I'm now into management, and I'll get back off that tangent. So external rotation and strength is very important. I'm now going to finish off my shoulder examination by showing you instability. And instability is very crucial because we often see cases whereby we had, David, do you remember the young man that we had a young man referred to us by a Scarborough physician, by Dr. Butt. He's a hockey player, and he dislocated his shoulder in June, and the dislocation resolved, but he still has shoulder pain. We decided that shoulder pain is just rotator cuff tendinitis. And so we have to acknowledge that in some of these cases there is a component of instability. And Judy, you're our storyteller, so I'm going to get you to come on over here. And Lynn, I'm going to roll this up a little bit higher. Can you come around this side, Judy? And what I'd like you to do is I'd like to take your forearm and place your forearm against his scapula, reach right over the top, and grab his clavicle with your fingers like that. Can you do that? All right. Now, if she's got him in this position, it's less likely that the whole thing is going to move, the scapula is going to move as I pull down there, okay? And I think that's really crucial, that I do this same type of thing when I examine the foot and ankle. I lock the foot by having it rest against my forearm, and so by locking it that way, you can actually do these tests. Did you want to just grab there again? So push your forearm right from your elbow if you can into his scapula. That's right, you've got him. Is she tight there, Len? Good, okay, thank you. So I think it's really crucial that you actually reach over the top and hook your fingers underneath the clavicle there so that you actually have got some stabilization on the scapula. Thank you, Judy. And so what I'm going to do is I'm going to lock Len here, and I'm actually going to grab him supracondylarly, it's a tough word to say at 9 in the morning, at the elbow, and I'm going to pull down like that. Now, what I'm looking for is the humerus to come down away from the acromion and cause a big, shallow sulcus. And that's called the sulcus sign. Okay? And then from that position, I'm going to take my third and fourth fingers, press posteriorly on the anterior aspect of the humerus, and then take my thumb and press anteriorly. And that's called the AP load and shift test. All right? So the next tests that I do, Len, do you want to come on over here with me? We're going to go to the table. Feroz is going to catch you if the table's going to collapse. So